the diseases and the lesions of the spinal cord. The brown secret syndrome, hemisection of the spinal cord. The hemisection may be from front to back, or it may involve only the anterior quadrant or maybe the posterior quadrant. If the hemisection is from the front to back, it produces both ipsilateral and contralateral features. The ipsilateral features it produces is muscle weakness due to the involvement of pyramidal tract, because the pyramidal tract in the spinal cord are in the lateral white funiculus, and then it produces atrophy of the muscles and loss of reflexes, and there is loss of joint position and vibration sense ipsilaterally because of the posterior column involvement, because they don't cross over there, they cross in the medulla, in nucleus, cuneatus and fasciculus. But it produces contralateral side loss of pain and temperature fibers because of the involvement of the spinothalamic tract, which cross over a little 1 or 2 segments when they enter into the spinal cord. The second condition, if it involves only the posterior quadrant, then there is loss of vibration and position sense because it's the involvement of posterior columns only. The anterior horns and the motor system is spared. The third condition, in which if it involves only the anterior quadrant, then there will be ipsilateral muscle paralysis and there will be contralateral pain and temperature loss, because pain temperature fiber there in the anteriorly along with the anterior horn side, anterior gray matter. The central cord syndrome. The causes of central cord syndrome are trauma, tumor, syringomyelia and anterior spinal artery syndrome, because the anterior spinal artery supplies anterior 2/3 of the front of the spinal cord. The posterior 1/3 is supplied by the right and left posterior spinal arteries. If it's involved the cervical area, it produces arm weakness more than the leg weakness, and there is pain and temperature loss in cape distribution over shoulder, neck and upper trunk. The position and vibration sense are intact, so posterior column is not involved in central cord syndrome. The anterior 2/3 syndrome. The anterior 2/3 syndrome spares the posterior column, that is position and vibration sense, because the posterior column is posteriorly. All the spinal cord functions, motor, sensory and autonomic, are lost below the level of lesion in anterior 2/3 syndrome. The extramedullary lesions. In extramedullary lesion, there is a radicular pain and early sacral sensory loss due to the involvement of lateral spinothalamic tract. I would advise to go to see the sensory and motor tract discussion so that it will be easy to understand this. We have discussed it earlier in that. And then it produces spastic weakness in the legs because of the corticospinal tract involvement. The intramedullary lesion. The intramedullary lesion inside the spinal cord, they produces burning pain, and it spares the sacral lesion, and the corticospinal signs appear late. The cervical cord lesions. The outcome of cervical cord lesion depends on the level of cervical cord which is involved. But if it involves the upper cervical or medullary region, it's life-threatening and it may cause quadriplegia. And because of the respiratory muscle because of the phrenic nerve involvement which supplies the diaphragm, there is respiratory muscle weakness. The lesion at cervical 4 and 5 produce quadriplegia, and respiratory muscles are spared in that. But the lesion at cervical 5 and 6 they spare the shoulder, but they affect the biceps and brachioradialis reflexes, which are lost. Lesion at cervical 7 spares the biceps and brachioradialis reflexes, but that produces weakness of the finger and wrist extensor and loss of triceps reflexes. Lesion at C8 paralyzes the finger and wrist flexors. The thoracic cord lesions. Lesions at T9 and T10 produces paralysis of the lower abdominal muscles. Thus, umbilicus is directed upwards when abdominal muscle contract, and this is known as Beavor's sign. The conus medullaris lesion. Conus medullaris, as you know, the last portion of the spinal cord, and a lesion over there produces bilateral saddle anesthesia. There is bowel and bladder dysfunction, urinary incontinence, and the anal sphincter is lax. This is conus medullaris lesion. The spinal cord infarction. The anterior spinal artery, which is a single artery and runs in the anterior median fissure, supplies the anterior 2/3 of the spinal cord. The two posterior spinal arteries, they supply the posterior 1/3 of the spinal cord. The spinal arteries arise from the vertebral arteries. The feeder arteries, they involute before the birth, but a few are left. The anterior spinal artery feeders, they occur at two levels, cervical and thoracic. At the cervical it's C6 and upper thoracic, and at T11 to L2, that is artery of Adam Quicks. These are the two feeders, very important. The anterior spinal artery may be discontinuous, so feeders are helpful in those cases. If the infarction occurs at T3 and T4, then there is low blood pressure, and there is a sign symptom of weakness, spasticity with little sensory changes resembling ALS, amyotrophic lateral sclerosis, because it spares the sensory changes because posterior columns are not affected. So what are the features of acute infarction of anterior spinal artery? Remember that it supplies the anterior 2/3 of the spinal cord, so it will spare the posterior half. So there is paraplegia or quadriplegia and loss of pain and temperature, and it spares the vibration and position sense, the posterior column. There is loss of sphincter control, and it is acute in onset. The partial infarction of one anterior hemichord, what does it produces? It produces hemiplegia or monoplegia, loss of pain and temperature, crossed, and initially areflexia due to spinal shock, but later there are increased reflexes and spasticity. The epidural tumors may compress the spinal cord and may produce anterior spinal artery syndrome if it's anteriorly. The posterior, what the posterior spinal artery infarct produces? The posterior spinal artery infarct produces posterior column loss. The causes of spinal cord infarction. The causes are atherosclerosis, dissecting aneurysm of aorta that produces decreased pulses in the lower limb, and decreased blood pressure, thoracic infarct, or the cardiogenic emboli may cause spinal cord infarction, vasculitis secondary to collagen vascular diseases, surgical clipping of aortic aneurysm, trauma or exercise may lead to embolism of nucleus pulposus into the spinal arteries. Diagnosis of spinal cord infarction. Apart from angiography, MRI is normal in spinal cord infarction, but it excludes the other causes. LP for underlying vasculitis, VDRL for aortic and cardiac diseases and hypercoagulable states. Anticoagulants are contraindicated in thromboembolism. The epidural hematoma of the spinal cord. The causes of epidural hematoma are trauma, tumor, blood disorders, lumbar puncture, epidural anesthesia, low molecular weight heparin, and it may also be idiopathic. There is an acute pain followed by the spinal cord sign symptom, the involvement of spinal cord. The external spinal cord compression from any cause is a medical emergency. The diagnosis is done and confirmed by MRI. It confirms the epidural hematoma. The lumbar puncture is avoided in blood disorders. The epidural abscess. The triad of clinical features in epidural abscess are pain, fever, and rapidly progressive weakness. Pain is almost always present in epidural abscess for 2 weeks or more. Epidural abscess is a medical emergency. Spinal cord injury results from expanding abscess due to venous congestion. So epidural abscess compresses on the spinal cord and causes injury because of the venous congestion and thrombosis, thrombophlebitis of the epidural space, spinal artery disease, or cord compression. Once the weakness and spinal cord sign symptoms develop, progression is rapid. The risk factors for epidural abscess are decreased immunity, as occur in diabetes mellitus, renal failure, alcoholism, and malignancy. Number 2, IV drug user may also develop epidural abscess. Skin infection, furuncle, boil, carbuncle may lead to epidural abscess, dental abscess, and deep viscera involvement like bacterial endocarditis can also lead to epidural abscess. 2/3 of the cases of epidural abscess are due to hematogenous spread from skin or soft tissue. So the most common cause is hematogenous spread. 1/3 of cases are due to direct extension from local lesions. For example, vertebral osteomyelitis, decubitus ulcer, lumbar puncture, or spinal surgery may lead to epidural abscess. The organisms involved in epidural abscess are Staph aureus, gram-negative bacilli, strep, anaerobes, and tuberculous bacilli. With increasing age, immunity decreases, so the number of cases are increased. Diagnosis for the abscess is done by MRI. MRI localizes the lesion. LP is only done if meningitis or encephalopathy is suspected, because LP may cause herniation, and so high cervical tap is safe. In the CSF there is pleocytosis, polymorph nuclear leukocytosis, increased protein and decreased sugar. Bacteria eats the sugar, so protein increase, sugar decrease. Blood culture is positive only in less than 25% of cases. Hematomyelia. Hematomyelia is a rare disorder and it may be caused by trauma, tumor, infection, arteriovenous malformation, blood disorders, vasculitis due to polyneuritis. The signs and symptoms are acute painful transverse myelopathy, and the diagnosis of hematomyelia is done by MRI. Surgery is generally not useful. Spinal angiography for arteriovenous malformation and surgical removal is done. Transverse myelitis. In transverse myelitis, there is neck or back pain followed by paresthesias, sensory loss, motor weakness, and sphincter control within hours. So it's acute disorder. The partial form may involve posterior column or anterior spinothalamic tract. In transverse myelitis, it starts with dysesthesia may begin in the feet and they ascend up symmetrically or asymmetrically, first in one leg and then in the other. Involvement of the trunk and sharply demarcated spinal cord level indicate myelopathic nature, not the GBS, Guillain-Barré syndrome. In transverse myelitis, areflexia, if it occurs, it indicates a spinal shock, but soon hyperreflexia occur. So areflexia is a feature of shock, but usual feature is hyperreflexia. Persistence of areflexia, if it is persistent, then it indicates a spinal necrosis, is a bad sign. May be post-vaccinal or post-infectious. One of the causes may be post-vaccinal or post-infectious, may occur after influenza, MMR vaccination, Epstein viral infection, Guillain-Barré syndrome, and cytomegalovirus infection. If there is no organism isolated, then it suggested autoimmune disorder. Multiple sclerosis may present initially as transverse myelitis. What is Divx disease? Divx disease is a demyelinating disease that presents at transverse myelitis with bilateral optic neuritis. Transverse myelitis is a recurrent disorder and is associated with other autoimmune disease also. So the sarcoidosis may produce subacute transverse myelitis with severe cord swelling. The investigation, MRI shows cord swelling, diffuse or multifocal areas of abnormal bright signals extending over several segments. This is very important. The bright signals, cord swelling with bright signals on MRI over several segments. This also excludes, the MRI also excludes spinal cord compression. A brain MRI should also be done to exclude the initial attack of multiple sclerosis. Finding of multiple periventricular bright lesions indicate more than 50% chances of multiple sclerosis. So in transverse myelitis, a brain MRI should always be done to exclude multiple sclerosis, and if there are multiple periventricular bright lesions, is more than 50% chances of multiple sclerosis. How about the CSF in transverse myelitis? The CSF may be normal in transverse myelitis. Otherwise, there is pleocytosis with several hundred mononuclear cells. polymorph nuclear leukocytosis in rapidly evolving severe cases. Protein is normal or slightly increased. Oligoclonal banding indicate further evaluation for multiple sclerosis. So if there are oligoclonal bands, there are chances of multiple sclerosis. Acute infectious myelopathies is rarely bacterial. The organisms involved are Listeria monocytogenes, herpes zoster virus, which is the most common cause of acute infectious myelopathy, and polio. Poliomyelitis is the prototype of this disorder. The other causes is CMV, cytomegalovirus, Epstein-Barr virus, and herpes simplex virus type 1. So the most common cause of acute infectious myelopathy is herpes zoster virus, and polio is the prototype.